Hearing from VELscope. They're going to be talking about advanced detection of head and neck screening. And the speaker today is Eben Turner. He works with VELscope. He will be giving you a code at the end for your CE credits. I would also like to invite you to look at our webpage at tdaperks.com. We've got a content page on there that's got everything from journal articles to podcasts as well as these webinars. And like I said earlier, this webinar will be recorded and you can go ahead and look at it later. And we also host a monthly webinar series of different presenters from our endorsed partners. And they'll talk about everything from cancer detection to social media integration into your practice and how you can best leverage that for your job. That being said, I would like to turn over the presentation to Eben. If you have any questions throughout the presentation, hop down into the questions section and you'll be able to type in any question, and I'll be monitoring that, and I'll hop on the line and help Eben so that he can find an answer to your question. And then also, if you would like, you can go to the handout section if you don't already have the email that was sent yesterday with the form that needs to be filled out for the CE credits. Again, thank you very much for attending the webinar, and with that being said, I'd like to turn it over to Eben.
Thank you so much. Thank you all for attending. Happy Friday to all. I'm just going to get right into it, so obviously we'll utilize our time effectively. Number one, to sort of follow up on the questions. I think we should answer many questions that you have as we go throughout the presentation, but obviously if there's something that we don't go over, please make sure to ask. Real quickly, I want to make sure that we understand this is a CE program. It is an AGD approved PACE CE, and with that, at the end of the program, there is a survey that I would ask you to please fill out. That survey then can be faxed or emailed to us, and we'll provide that information. We also will be providing a code that you can put on that form before you fax it or email it in that we need as well. And then once it's received and confirmed, then we'll be emailing out your certificate. So getting started. I know that there's, to some degree, misconceptions, misunderstandings about this whole category of screenings and oral cancer detection and so forth. And I want to step back a second and ask you to think about what you folks do every day. And if you really think about it, at the core of everything that you do, it really is about prevention. Whether you're doing bite wing radiographs to see if there's caries, and hopefully you're capturing those caries at an early stage. Periodontal disease, you're capturing it, hopefully at 2 and 3 as opposed to 7 and 8. And then obviously when we talk about oral abnormalities, specifically related to oral cancer, our goal is to prevent oral cancer. And so if we really believe in preventing oral cancer, how do we do it? And that's really at the core of our discussion today. Our goals are not to find oral cancer, because unfortunately once we find oral cancer, it's too late. Just like breast cancer, we don't want to find breast cancer. That's why we have mammograms. Same thing for cervical cancer. That's why we do pap smears. And we know when we can find things early, we can prevent those cancers from occurring. In the same case with oral cancer, our goal is to prevent it from happening. And so I know this is a rhetorical question, but I ask you to really think about, do you really believe in prevention of oral cancer? And if you do, then hopefully we can help facilitate that process more so. Because we know obviously at the end of the day, when we prevent anything from occurring that could be deadly, we know we're going to save lives. So a few statistics that I just want to share with you that I'm going to put this, if you will, in your mouth and say alarming. These numbers should be considered alarming. And they're alarming because for two reasons. Number one, the numbers have progressively increased over the last 10 years, but number two, most people aren't aware of them. If you look at about 10 years ago, where the numbers were at, about 31,000 oral cancers were detected. We're now looking at, probably by the end of this year, almost 46,000. We're talking about a 47% increase. Now, if this was breast cancer, lung cancer, and someone would say, hey, there's been a 47% increase in those cancers, I guarantee you would hear about it more in the media, testing water, hey, what's going on? Unfortunately, I believe because oral cancer tends to be in the purview of dentistry, and because a lot of times once it's detected, it's systemic, it's in other organs, unfortunately it sort of gets lost and it doesn't get that attention that it should. And part of our goal is to hopefully help you to educate your patients why what you're doing every day is so important, because as your patients become aware of what you're doing, hopefully that message is spread, and then at the end of the day it really comes down to the general public understanding, you know, this is a serious issue and something that should be looked at every at least once a year. Sort of putting it in comparison, obviously everyone's familiar with cervical cancer. I've done presentations to OBGYNs and I've specifically said, you know, tell me about your cervical cancers. And basically the patients who don't get cervical cancer, the patients who get cervical cancer now are generally patients that don't get pap smears. So with that, Dr. OBGYN, are you aware that your patients actually have about a 3 times greater risk of any oral cancer than cervical cancer? And it's pretty amazing how their eyes open up. And we'll talk about this link in terms of why an OBGYN would be cognizant of that. But I would ask you to think about your patients and maybe just consider doing a little survey and ask one of your patients, hey, you know, Mr. Smith, what do you think are the top 10 cancers? And they'll say colon, you know, I guarantee you they'll say cervical, breast, lung, pancreatic, prostate. But the reality is, unless someone has some type of patient or relative that they know of have had this disease, they won't say oral cancer. In fact, I guarantee you 9.9% of your patients would not put oral cancer in that category. Oral cancer now is the 6th leading cause of cancer among men. It's number 9 among women. Going back to that graph, 2006, actually just 5 years ago, it was number 9 among men, 13 among women. So unfortunately, oral cancer is going in the wrong direction when it comes to the numbers of cancers. And in all fairness, some other cancers are going down the list. But the reality is we're talking now the 6th leading cause of cancer. Now that's something that people should know, and they don't. So I mentioned OBGYN and why. You know, why would we be having this conversation? And it's because hopefully, as all of you know, there's a definitive link now between human papillomavirus that causes cervical cancer and now oral cancer. So this was a hallmark study that came out of Johns Hopkins that basically confirmed that HPV, at least specifically in this study, was being transmitted through sexual activity and eliminated all the other risk factors like tobacco and heavy drinking and so forth. So we know HPV is obviously a link to forming oral cancer or causing changes associated with oral cancer. Now, for you as clinicians, you know, for those that maybe in dental school 5, 10 years ago or older, a lot of times it was, hey, you really had to focus on the elderly, the heavy smokers, and the, you know, unfortunately the patients that tend to drink heavily. And generally, those patients would have a higher risk factors for floor of the mouth, lateral borders of the tongue. But now with HPV, we're now seeing those changes occur further back. So now posterior lateral borders as well as the tonsillar papillary areas. So what does that mean? That means just doing your white light examinations, that means you really have to do a much more aggressive amount of exposure, especially in the back of the throat, to see those potential changes, because it tends to be a lot more challenging to see those. And with that, hopefully, you know, just doing what you're doing, we see something. Obviously, our goal is to see it before it's obvious. But at the end of the day, you know, when we really look at these specific strands of HPV 16 and 18, if you look at some studies and publications, they're talking about epidemic when it comes to the infection rates associated with this virus. So I'm going to try to connect the dots here a little bit further. So in 2007, when this study came out, about 27% of all women, when they tested for HPV, were positive. So, and pretty, I guess, consistent with you know, the cervical cancer rates as well, if you look at sort of where they were at. So 2007, 27%. Study came out a couple of years ago that said when they tested for HPV, over 40% of all women were positive for HPV. Another study that was published showed when they tested college-age students over 60% of those patients were positive for HPV. So when we look at the prevalence, you basically have to assume if you have a teenager, let's just say 16 or above, you just have to assume that they potentially have at any given point an infection associated with HPV. Doesn't mean they're going to get cervical or oral cancer. What it means is that they are a high-risk category. So now we saw that increased rate of HPV infections. We're seeing an increased rate in oral cancers, and this was a sort of study that sort of brought it all together that said when they tested for patients that had been biopsied with oral cancer, and then they obviously tested those oral cancers, they showed in over 50% of the time HPV was present in that biopsy. Now, in the study, they said we can't say that HPV was necessarily the cause of the cancer, but when we see a significant increase like we've seen over the last 7 years, and from that, that significant increase in oral cancers and HPV infection rate, it makes sense. The scary thing about it is a recent study came out that said probably by the year 2020, the majority of oral cancers will be HPV related. That's only a few years away. The thing about that is if we're seeing HPV, as we see more HPV-related oral cancers, that means we're seeing a much younger population and unfortunately a population that don't have those traditional risk factors like smoking and drinking. Now, not to scare those that have teenagers, but I just want to reiterate that this virus has been shown now to be transmitted just through open mouth kissing. What does that mean? That means you don't have to be technically sexually active anymore. You just have to do what normal teenagers do. And with that, it reinforces why you could have that star athlete student that's in your chair, and you have to look at that patient and do an examination as thoroughly as if that patient was a 6-year-old smoker. And that's not me saying it. That's actually a statement that came out of the World Health Organization that talked about this significant increased risk associated with HPV. So a question out there for you folks. What you think about this for those that have found oral cancer, but then I guess just in general, who do you think finds more oral cancers? You, dentists and hygienists, or primary care physicians? And I think we all know that when it comes to doing a thorough oral health examination, by far, dentists and hygienists are much more skilled at doing a thorough oral cancer exam than a physician ever would be. But surprisingly, even though logic would tell you that dentists and hygienists would be the key diagnosers, it's actually primary care physicians. And what does this mean? And I want you to really think about this for a second. So you guys do a much better job of identification, but primary care physicians are finding it. And generally what happens is if a primary care physician is finding oral cancer, it's a late stage, it's obvious. There's a bump or some type of lump in the throat, patient has this earache that isn't going away, this sore throat that is persistent. And from that, sometimes doctors prescribe antibiotics, and it's 3 months later, still not away, and let's refer. And again, it's symptomatic, it's obvious. And that's the scary thing about oral cancer. Unfortunately, it tends not to present itself until it's already late-stage symptomatic. The thing about that, though, is I say that's opportunity for you as clinicians to educate your patients, number one, in terms of what you're doing every day. If you're not letting them know you're doing a thorough oral health examination, which includes detection of abnormal tissue, if you will, you don't have to say necessarily oral cancer, but a thorough oral health examination, I think you're missing an opportunity. And the reason being is let the patients know that, hey, if there's ever something of concern that isn't resolving, it's not going away after, or something that's out of norm, give us a call. Let us assess what to do. And I think you're apt to be much more effective and aggressive potentially than a physician ever will be. And I think it also establishes a higher level of standard of care for your patients in terms of how they perceive you as hygienists and dentists as being purveyors of the oral cavity and not just tooth fixers, if you will. So I started off talking about prevention. And I just showed you, though, a slide that said, unfortunately, we're not preventing it because most primary care physicians are the ones identifying oral cancer. This was a study that came out of JET a couple of years ago by an oral pathologist, very well respected, and he did a thorough analysis of a variety of studies associated with oral cancer examinations and screenings and so forth, and basically concluded that it didn't matter how great the clinician was, and we're talking general dentist predominantly, didn't matter how great the general dentist was in terms of doing a thorough oral cancer exam. The reality was the dentist is finding changes, but they're already cancer. What the dentist isn't finding are changes that are precancerous. And so if we're trying to prevent oral cancer and we're only finding it when it's cancer, how do we prevent it then? And that's the primary reason why I think we continue to see these numbers go up and up and up. It's because, unfortunately, we're still finding it only when it's already cancer. Obviously, our goal is to prevent that. So I throw this up there because if the question isn't asked, it always is asked about liability. So I'm based out of Chicago, and in Chicago, if you're familiar with sort of how the highway system works, there's these, there's a sort of like a loop outside of the city, and there's five or six billboards, this specific billboard now that's up around. And this came up, now it could be purely coincidental, but there was a major lawsuit by a world-famous chef. Unfortunately, that was misdiagnosed. He sued two dentists and I believe an oral surgeon. And I apologize, I don't recall which, two of the three lost. And it was published in USA Today. So this was a national story that went out. And all of a sudden, this billboard went from just mesothelioma to now included throat cancer. So, and people just put throat cancer in that whole category of oral. So with that, I bring this up. Adjunctive technologies are not going to decrease or increase your liability. What's going to decrease your liability is thorough documentation, so much so that I've had programs with wrist injectors that talk about now considering, instead of saying, within normal limits or oral cancer exam negative, actually be more descriptive, right lateral border of the tongue negative, left lateral borders, floor of the mouth, more descriptive so that if someone comes up and says, well, how do we really know you did an exam? Well, hey, I demonstrated that I did a thorough exam. But I will also say this, you saw those numbers, we're talking about 48,000 by the end of this year. Oral cancer is the second leading cause of malpractice in dentistry. And obviously, as more and more cancers, or as these cancers increase, it just becomes a bigger target for lawyers. So again, make sure that we're properly documenting and obviously doing a thorough exam as we can possible. So the thing about oral cancer that unfortunately is so devastating, it's not just the loss of life that occurs. So we have about a 50% survival rate after 5 years. So for that other 50%, it's a devastating disease. So generally, as we all know, unfortunately, it affects speech. As we can see, jaws are removed. The third picture, this is actually Tony Gwynn. And if you're familiar, for those that may not be familiar with Tony Gwynn, a famous baseball player, unfortunately died a couple of years ago. He was a dipper though, so obviously there was a cause and continued dipping after he was diagnosed. But 3 surgeries, and unfortunately after each time. But if you just read the stories about, he had a partial paralysis after one of the surgeries, just the radiation burns and so forth. What I think is interesting, and hopefully it's something that we can talk about when it comes to insurance, but oral cancer now is the most expensive cancer to treat of any cancer. It's more expensive to treat than lung cancer, breast cancer, because generally what occurs is there's multiple surgeries, it's plastic, it's occupational therapy that's required, there's gastric changes that occurs many times because of the lack of saliva production. It has the highest suicide rate of any cancer because unfortunately you're malformed, I was at a program once, and the hygienist was talking about her stepmother that was diagnosed, and her grandchildren were afraid of her because, unfortunately, the massive surgery associated with her mandible. So, again, we're not just trying to prevent death. We're trying to prevent all these other associated factors with oral cancer. And, you know, if we can not only save money from the health system, but obviously we can save someone's standard of life or quality of life. We have a huge opportunity there. So, prevention. How do we prevent? So, one example of prevention was utilizing a technology called tissue fluorescence visualization, and actually began about 17 years ago for lung cancer screening. So again, what they found is they incorporated this using a safe certain wavelength and put it into a bronchoscope. And in that bronchoscope, they were able to increase sensitivity by over 50%. It became standard of care for lung cancer screening in a little less than 2 years. Now, that's one thing about medical that's pretty common. If you see an impact, especially when it comes to cancer, you'll get adopted fairly quickly. Now, probably isn't used as readily as much because you have CT scans and so forth. But again, something that is proven, well studied. And so taking this technology, what we did is develop something that could be utilized for the oral cavity. The way tissue fluorescence works is we're presenting a very safe blue light. It presents all the way down through the basement membrane. Basement membrane is key because that's where those abnormal dysplastic cells begin. From that, first thing these dysplastic cells want to do is start to break down collagen in that basement membrane. As soon as the collagen matrix starts to break down, we actually are able to identify that. And we do that by this special wavelength, again, completely safe, but this blue light, when that collagen, and a few other things, but predominantly collagen, when it's in a normal state, it actually absorbs that blue light and actually gives off a response. And that response is called fluorescence. It's a wavelength you actually can't see with the naked eye, but there's filters in our handpiece that allows us to identify that response. And if it's normal, healthy, it'll appear green. When it's abnormal, it's dark. And it's dark because predominantly that breakdown in collagen inhibits the response. So extremely simple. And when we think of other forms of screening, you know, pap smears, mammograms, PSAs, prostate exams, it's definitely much more, not only is it faster, it's more convenient, it's easier, and again, no discomfort to the patient. So I'm not sure how many of you are familiar with VELscope. The technology specifically for oral cancer screening has been out for about, going on 9.5 years. Now, this is the initial model that came out, and a couple things. Number one, this model was extremely bulky. It was, I had to plug it in. It was about 8 pounds. It wasn't very convenient in terms of taking it from operatory to operatory. The other thing, though, is if you notice it says oral cancer screening system. And the reality is that we quickly found out that this wasn't about detecting oral cancer. It was about oral assessment. It was about the ability to identify abnormalities that weren't just precancerous related, but a variety of other things that provided direction for clinicians to better manage and care for the patients. And so about 2.5 years ago, we came out with a different model. And that model I'll show you in a second. But the technology itself is FDA approved. And I bring this up because every now and then I'll get a call from a doctor who'll say, hey, I have a physician in my chair, or I had an engineer, and they're saying, hey, is this a gimmick? You know, I've never heard about this. How come doctors don't have this in terms of medical doctors? And the reality is this is standard of care in lung cancer screening, and this is FDA approved to be used for oral health examinations, which includes the detection of precancerous and cancerous lesions. What's exciting about this technology, though, is the studies have now demonstrated, which has allowed further expansion of FDA indications that say that it's actually being used by surgeons to help them define the margins to where we're now demonstrating that when surgeons use this to assist in the surgical process, we're actually showing a decrease in recurrence of the oral cancer. And we have a lot more studies that we can review at a later date. So this is the VELscope. It's handheld, portable, rechargeable, much smaller than that previous unit that I shared with you. You can see there's a blue light. We're presenting that directly to the oral cavity. Again, no discomfort. You can see there's goggles that the patient has on. It is not required. It's just for patient comfort because it is a bright light, but no one else in the operatory needs to wear them. Literally, you're doing your same protocols up and down, left and right, floor of the mouth, back of the throat, taking no more than a minute, minute and a half max. Here you see the clinician is holding it up to his eye. You can actually, though, do an exam wearing your loops. And from that, it's something that, it's pretty straightforward, and we'll show you the pictures. So now imagine we're doing our exam, and just to quickly show you an example of what we're looking at here. What we see here is a example of looking through the VELscope. This is actually, and I'll show you how we do this really easily in terms of doing an exam, but up and down, left and right, floor of the mouth, we see green here, and you see a little red too. That's actually the bacterial response. But full exposure, and from that, something that provides an immediate response if there's something of concern in the oral cavity. So starting to get into more, obviously, how does this actually look? And here we see what we're going to see in about 98% of all patients, nothing but healthy green tissue. What you notice is a little vascularity, which is actually great for us, and we'll describe in a second why that's so beneficial, because what we're actually seeing there is hemoglobin in the blood. And why that's important, because hemoglobin helps give us information in regards to if areas of concern are trauma or inflammatory or something else. But again, this is what we're going to see in, again, 98% of the time. Now here I have a picture. I don't know if there's anything that would concern you. I can tell you the GP who took this picture wasn't concerned. But from that, see a little squiggly line. So I would ask you, what's more apparent? This area under white light or this area under the VELscope? So green is normal, black is abnormal. And I want to stress, abnormal. This is not diagnostic. We don't know what this is. What this says is concern. Now, how we reinforce our level of concern is we're incorporating our standard clinical processes of assessment. So imagine this was a big red spot that you could see clinically. What would you do? Obviously, you're asking questions of the patient. Now, Mrs. Smith, have you had something? Have you, maybe jabbed something back there? Have you noticed something back there? How long have you noticed it? Is this bilateral? Obviously, it's irregular shape. Does it persist for 2 weeks? And we'll talk about with the VELscope, but there's another technique that's going to help us reinforce our area of concern. But from that, patient comes back 2 weeks later, still present. That says, we need to get this checked out. And it comes back biopsy confirmed as CIS, which is great. So we caught it before it became squamous cell, which means two things. Number one, it's going to mean a much less extensive level of surgery to remove it. Then number two, obviously, the likelihood of this patient obviously living is significantly higher. So one of the things that I mentioned to you is hemoglobin absorbs its wavelength. You see a red spot on a denture. How do you really know it's a denture sore? You assume it is. The beauty of the VELscope is you're going to know it is. And the way we're going to know that is, when you see something of concern, the first thing you're going to do is take your Explorer back of your mirror and gently rub across it. If you see it turn green or almost light white in color, as you see as the hygienist actually is moving that Explorer across, that tells us this is a denture sore. It's inflammatory traumatic. If this stays dark when we rub across it, that increases our concern that this is something at the base of the membrane that may be associated with dysplasia and therefore requires additional follow-up. So this is where the assessment process really becomes so beneficial. And actually this specific aspect of utilization of the VELscope is so helpful in terms of the overall patient management. So this patient was referred for the polyp. Thank God they had the polyp, because if it wasn't for the polyp, they may not have found the CIS or dysplasia located adjacent to it. So doctor was initially concerned about the little red areas there, just assume they're irritation. I'm sure you see this pretty regularly with your denture patients, but I will reiterate, this is why you need to have your denture patients come in at least once a year, because a lot of times they do have some trauma associated with malfitting dentures. And in this case, doctor was like, we want you back in 2 weeks. Called up the patient 2 days before, Ms. Smith, just want to make sure you're going to be in for your appointment. And what they found was, you can see in the vestibule, there's a little gray area, and that's just irritation from the ridge of the denture, and we know that because when they rubbed across it, it turned green. However, that other area on the ridge of the denture did not turn green. It stayed dark. So this turned green here. This stayed dark, warrants a referral, and comes back as severe dysplasia, again, which is fantastic. So we caught it early. We're saving that patient's jaw, and more importantly, you're just removing that dorsal or that top layer of tissue. So, doctors, one of the things that I think is challenging for you is, based on statistics, 30% of all your patients have some form of oral abnormality at any given time. And I feel pretty confident you're not referring 30% of your patients, every day or every week or every month. With that, though, it means you're observing things that you assume are probably benign. And the reality is you are sort of guessing that it's okay. Our goal is, how can we give you greater confidence in terms of feeling comfortable to observe versus refer? So here goes 2 lesions, leukoplakias, which again I'm sure you see pretty regularly. The first one on the left, fairly large under the border of the under the tongue, and you can see this one is a little more prominent on the right. These were actually both in observation mode for over 2 years, and with that, this first one we're not observing anymore. This is unilateral. It's irregular shaped. You can see that differentiation between green and dark. It stays dark when we rub across it. And again, we talked about that blanching technique. All of that says, you know what, we need a second opinion. Second opinion comes back as severe dysplasia. Again, I can't reiterate, but we say fantastic. And we say fantastic because that means the surgeon's just going to remove that top layer of tissue as opposed to removing half that tongue. But the reality is most of these leukoplakias you're going to see are going to appear green under the VELscope. And that gives us the indication it's benign. Now, this is actually part of a study, and therefore it's biopsied and it came back as hyperplasia. So linear alba lichen planus, hyperplasia will show up as green or light green. Now, I'll stress, it doesn't mean we ignore this. The goal is what's causing this. And so, is it a sharp cusp? Is it an allergy? If it's still there 6 months, 9 months, whatever your criteria is, and you don't have a cause, proper protocol is to get a second opinion. But at least you're referring with a level of confidence that, Mr. Smith, I don't think that there's anything to worry about, but, we just want to make sure everything's okay. And so from that, again, this is where confidence not only increases for you, but also for your patients, especially those every now and then that might have some concerns about something that may be presenting itself that obviously could be concerning. So this patient was referred to the oral pathology department at NYU, and when the oral pathologist pulled out his VELscope, he saw this black area at the floor of the mouth, sent us back this picture and said, hey, look at this area. And you can see on the left, it seems to be a little bit raised, and the explanation for the oral pathologist was, the doctor was probably focused on the lip, and, fortunately he had that. Maybe if that lip, that hemangioma wasn't there on the lip, maybe you would have seen the floor of the mouth. Unfortunately, this was stage 1 squamous cell carcinoma. So 2 things. What I would say is, first and foremost, if you saw it on the left, what's more apparent, the left or the right? What are you probably not going to miss? Number 2, I would say, too, what if we were able to screen this patient a year before? Maybe this wouldn't have been squamous cell, and hopefully would have been able to detect it at that point, too. A few other pictures, another area, not readily apparent clinically, definitely much more under the VELscope. Again, this is unilateral. It's irregular shaped. It stays dark when we rub across it. It's still there after 2 weeks. All of that warrants a second opinion. And again, comes back as precancerous. Again, how do we prevent oral cancer? We prevent it by finding it in a precancerous state like this. So look at this large area. And then this is how, I want you to think about management tool, not oral cancer detection. And the reason being is here this patient, obviously, trauma probably caused by that broken molar, caused some changes, which warranted a biopsy, and it came back as mild dysplasia. What they decided to do is, because it's such a large area and it was mild dysplasia, they fixed the molar and they observed. And from that, they continued to monitor. I believe over a period of time it didn't really change, and so they ended up actually cryo-treating this area as opposed to excising it with a scalpel. But from that, imagine now they were able to monitor this. And why it's important? Because in many instances, dysplasia will regress to normal healthy tissue. And so if we can monitor it and now say, hey, maybe it's turning, it's getting smaller, now it gives us an opportunity to avoid surgery, if you will. The other thing is looking at the left, we don't really see anything. Unfortunately, if changes could eventually occur that wouldn't be apparent until it's already too late. So again, another way of utilizing this as a management tool for your patients. And a lot of things are going to show up as green or light green that tells us it's benign. Again, it doesn't mean we ignore it. Always should have a diagnosis because obviously you're going to treat different things differently. But from that, again, this reinforces at least a benign state. So last picture, there's definitely something here. I want you to look at this palette and think about where there might be something of concern. So be honest with yourselves. Who guessed that area? Now, for those that guessed, yeah, I saw that sort of area. My question to you is, if you saw that, what's more apparent to the left or the right? What are you not going to miss? And again, think about our criteria. This has that unilateral perspective. It's irregular. When we rub across it, it stayed dark, still there after 2 weeks. And from that, unfortunately, this was a salivary gland tumor, basically. But it was a low grade. This is categorized differently than squamous cell, which means our survival rate is much higher than obviously if it was a different grade. And these are pretty nasty. I would also say, think about how you do your palate exams. And this is another reason why you really want to make sure that you're doing a thorough palate exam, because unfortunately sometimes these changes are really difficult to see unless you're at the right angle. So one of the things, and I'm going to step back a second here. If you notice this picture, one of the biggest challenges we have with the older model is that you would, with your VELscope, would see something on the right, something that warranted a referral. Then it was referred to the surgeon, and the surgeon may not have a VELscope, and then he sees this patient on the left and doesn't really see anything that warrants a biopsy. And now you're like, well, there's something there. I'm concerned this could be cancer. And that was obviously a legitimate concern. I would call regularly, hey, what do we do? I see this area, it's not resolving, it's still there. Oral surgeon doesn't want to biopsy it. Is there someone else I can refer to, or is there a way that we can get a second opinion from someone? Or you'd have the dentist taking their VELscopes, their big bulky VELscopes, to the surgeon to confirm it. What we found was we needed a way to document that, both for the clinician from a review perspective, but obviously for referral. And the way we did that is we incorporated the ability to photo document. We've actually just come out, literally effective Monday, this option where you can actually attach, it's an adapter, you can attach an iPod that allows you to photo document. So that video that I showed you was actually a video that was taken through an iPod. And what's cool about it is there's an app that you can actually take pictures, store pictures on. You can review, you can compare, and most importantly, you can email these both to yourselves or download those into your charts or email them to the surgeon for review. Critical. I would tell you this is critical in the process of not only documentation, management, but appropriate care for the patient, especially if it requires a referral. But also, from one visit to the next, whether it's 2 weeks, whether it's 6 months or a year, really gives you the ability to appropriately assess. And lastly, it's just got a real cool effect that I'm telling you patients will really think is probably the most high-tech thing you have in your practice, and not lying about that. So from that, I'm not going to go into great detail. I would ask you can go to VELscope.com and see a list of over 25-plus studies on fluorescence in the oral cavity. There's more research on VELscope than every other screening device out there combined. And most of these are actually in peer-reviewed medical journals. And it's no offense to our demo journals, but there's definitely a fairly high level of standard when it comes to general oral factory surgery and head and neck. But I'll just share a couple of them with you, just so that you get a sense of where we've come. So this one study done out of University of Washington in the oral medicine department, probably one of the most well-respected oral medicine departments in the country. And this was, I don't want to say skeptical, but a doctor who I guess was just reserved before making any conclusions. And so the way the study was set up is that patients were actually screened first by oral surgeons, especially oral pathologists, oral medicine practitioners, oral surgeons, and surgical residents. And then they were screened with dental students with the VELscope. And from that, then they compared their findings. And what was pretty remarkable is that not only did the dental students find more lesions than the specialists did, they actually were able to more effectively assess what those concerns were. Were they trauma? Were they inflammatory? Were they potentially dysplastic or cancerous? And for us, why this was such an effective study is because you'll hear from your surgeon or your oral pathologist, hey, I can see this already. I don't need a special device. And the reality is that's absolutely true. Everything you refer to your surgeon is something that you see. And I think that's the mindset. Our goal is ultimately, first and foremost, hopefully to find things that are not readily apparent, because that's how we prevent, again, oral cancer. And this study just reinforced the fact that a dental student with VELscope in his hand was actually more effective in detecting lesions than the specialists were. This was a study out of British Columbia that came out, and what was, I think, very important about the study is that they incorporated it as an overall process. So they looked at white light exam and then exam with the VELscope. And what they found was that the whole process is important. In fact, for FDA perspective, you have to do a white light exam prior to a VELscope exam. And the reason being is, number one, you need to identify things. Well, you may identify something clinically, but you also have to palpate. You have to ask questions. That's all part of that oral health examination. And from that, VELscope is giving you more information. For those that wear loupes, I like to make that comparison. It helps you see better, just like if you wear glasses or wear loupes. But what this doctor concluded was that it really improved the ability to not only more effectively assess, but manage and appropriately then refer, so much so that they found they actually ended up referring less patients than they did before, but then also the patients that they did refer had a more specific correlation with something that required a diagnosis. And I say something because the reality is erosive lichen planus needs to have a diagnosis. Even if VELscope tells us that, hey, this is probably benign because it's blanching, unless you have a diagnosis, you're not going to treat it appropriately. So question always comes up, what about false positives? Are we going to be referring patients left and right? And the reality is no. I would first step back, though, and ask you to define a false positive. I think, unfortunately, sometimes in dentistry, from what I come across, the perception is if it's not cancer, it's got to be a false positive. The reality is if you look at the criteria for the American Academy of Oral Pathology, there's over 60 plus, in fact, it's even more than that, but 60 plus oral abnormalities that actually require a biopsy to have a diagnosis. Things like not candidiasis, erosive lichen planus is an example that I used. But from that, if we're combining this with our clinical assessment history, we go through that process of the blanching technique, obviously have the patient come back in 2 weeks. What we find is actually you should have a higher level of confidence of knowing what to do next. And the beauty of it is if you don't, it's okay. Now there's so many specialists, if you're using it, that we have that we can refer you to that hopefully can provide some guidance for you as well. So at the end of the day, we don't want to worry about false positives. We want to worry about appropriately referring when necessary. I'll ask you a question. For those that are men and they have mothers or wives 4 daughters that are appropriate age that require mammograms. And for the ladies that are out there, same criteria, whether it be for yourself or loved one. Would you ever recommend yourself or loved ones not to have a mammogram? And I've never heard the word no. Of course, you would have a mammogram when it's appropriate. False positive rate for mammograms is over 50%. And I think sometimes, but you never hear about that issue. The reason being is it's a screening process that facilitates direction. I feel pretty confident we don't have that same criteria with VELscope in terms of that type of number, but so part of that is subjective. But the reality is if you're following this process, you should feel very comfortable in terms of what you're seeing and what to do next with that patient. So implementation, how do we obviously incorporate this into our practice? Everyone has their own criteria. This is sort of recommended standard is patients who are 16 and above or whomever you deem as being an adult should be screened at least once a year. And that's just with the understanding you have to assume every patient is HPV positive at any given time, especially if they're of a younger category. Again, very important, you're still doing your white light exam and palpation, and then again follow that up with a VELscope exam. But the key is, again, the goal is to find precancerous changes, and that's why we really believe you have to do this at least once a year on every single patient. So a question always comes up about reimbursement and how do we get this to be accepted by our patients. There are codes now for reimbursement. D0431 is the dental code. There's actually now a medical code that's showing a lot of promise as of late. To be quite frank, I would say probably in your neck of the woods, the average coverage is going to be about 20, 25%. It's going to vary from region to region in terms of getting reimbursed. What we find is a lot of the medical-based dental plans, Guardian, Humana, United, actually tend to cover it more readily because they're the ones that are more concerned about the medical costs associated with treating oral cancer. Unfortunately, the Deltas of the world, there's really no incentive for them because once you get oral cancer, it becomes a medical liability. And you know better than I, the Deltas of the world, about cutting costs, not adding costs. But what we find, and this is very important, it doesn't matter. And I know that specifically, and I can say that with confidence. It does not matter if it's covered by insurance. What does matter is two things: how it's presented to your patients and what you charge. Well, we found that when the patient was educated, meaning they were given a brochure preferably before they go back to the operatory, and the fee is reasonable. Now, reasonable is relative, but national average around $20, we see over 70% of patients saying yes to having the exam. Now, what you find is actually the patients that tend to decline the most are going to be your drinkers and your heavy smokers because they don't want to know. But the reality is, if again we're presenting it the right way, and I will start, doesn't mean you have to charge. Doesn't mean you have to charge 20. Doesn't mean you can incorporate it in hygiene, increase hygiene. There's a lot of different ways to incorporate it. But the reality is, if a fee is involved, $20 a fee. I will say though, doing some surveys, we found that clinicians that actually charged the fee generally had more referrals than clinicians that gave it away for free. And what we found is that patients perceived a greater value if the fee was reasonable, and we're more apt to talk about it with friends and family than if it was just part of their overall examination. So I would say even if you don't charge, make sure when that patient's checking out, there's something on that invoice that says, VELscope exams, $25 waived. That reinforces the value, and appropriately so, the value that you're providing. So, it always comes down to, I always say whether it's, cone beans, whether it's VELscope, what have you, if there's a fee and it's not necessarily covered by insurance, VELscope's not something you do for a retirement fund. And I would ask you if it's a motivator for you or the reason why, then it probably isn't the product for you. What I will tell you that if you incorporate into your practice and put in a reasonable fee, it will pay for itself. It'll pay a light bill here and there. And at the end of the day, most importantly, you're providing better care for your patients. So this just gives you a sense of if you're charging a reasonable fee, doing 3 to 4 patients a day, it will pay for itself fairly quickly. It is considered a small piece of equipment, so with that, again, it'll cover for itself. So implementation, it's obviously we talk about that acceptance rate. Part of that is associated with this. So much material that's provided, both from a live webinar training to an extensive clinical DVD that has a variety of different abnormalities to review. We also have a training process involved websites that you can look at as well. And then lastly, we actually have a program that allows us to actually refer patients to a pathologist that will allow you to actually provide or get some direction in terms of what you should do with that patient if there's something of concern. So the topic of the presentation is enhanced screening, because obviously if we're enhancing screening, we're hopefully going to be finding things earlier. But in my experience, being in the dental arena now for many years, I've always found the practices tend to offer the best care, tend to be the best practices. And from that, I know I'm biased, but I really believe this is a phenomenal practice builder. And I say that because, number one, you're sharing what you're doing with your patients. You're making sure your patients understand why this is so important. And number two, when they're leaving, you're telling them, hey, this is something that every patient needs to have. Make sure you're sharing this with your friends and family. Let them know what we're doing. But I want you to also think about things that you do to promote your practice. And it could be mailers and all, it could be, advertisements, what have you. But what do you do outside of your office that allows you to interact with potential patients? And from what I've seen, there's not a lot of things you can do, maybe handing out cards at a health fair. I've seen numerous examples where clinicians are doing programs outside the office that are great for awareness first and foremost, but then also expose their practice. I'll just share real quickly. There's at number 2, I have a doctor. He basically looked at all of his patients, looked at I think the top 5 insurances that he thought were the best, and then looked at those patients and determined where their employees were within a certain radius. He then called those employers and informed them, hey, we do something for oral cancer awareness for free. We're concerned about this growing issue. Long story short, was able to set up a screening event at an IBM office, 10,000 employees in the office. It really can provide, and part of it is outside of the box, but from that, really provides an opportunity to get in front of a different environment that helps promote your practice. But more importantly, and I am sincere in this, expands awareness, because most patients are not aware of the risk associated with oral cancer. Here's just an example. Doctors, for those that do implants, on the left, and I'm sorry for the bad picture here, but this was a practice. What they did was they called up a retirement home, said we want to do free screenings. They said this was the best thing they ever did when it came to generating implants for their practice. And here's another example of a doctor did a screening in a hospital. He said the value wasn't all the new patients that he got out of the screening event. The value was all the referrals he started getting from physicians who are just as ignorant about oral cancer than the patients are. So here's a doctor, and I'd love to use this quote for him, because this is a doctor, practiced for 16 years, hadn't found one oral abnormality, and then in 2.5 years found several, and immediately saw the value, but more importantly, relayed that value to his patients, did programs with physicians in their offices, and the last time I saw him, he was talking about a referral that he got from a podiatrist of all people. So the key is, I guess I just want you to think about how you're going to utilize something that is not only going to be beneficial for your patients, but ultimately, hopefully that's going to, in the long run, benefit your practice as well. So I'm not going to go through all the details, but tons of awards. In fact, we were just awarded Best in Class from Pride, which is associated with ADA. Actually, we'll receive the award at the ADA this year. But you can look these up yourselves. The only dental device ever endorsed by the World Health Organization. So folks, I'm going to go back to prevention. You know, if you really believe in prevention, and based on the studies that show that we can't prevent oral cancer unless we find it early, but the problem is we can't find it early with a white light exam, how do we prevent oral cancer? And I would hope that through the pictures and information we shared, this technology provides the opportunity to find things early that will allow us to prevent oral cancer, that hopefully will allow us to have an impact in terms of changing the direction of this horrific disease. So I want to thank you very much for your time. Let me share with you, I'm going to share with you first our certificate code, 2390. So that survey that you have, if you could please put this somewhere. It doesn't need to put it at the top, doesn't matter where. This is my email address as well as fax number. So you can fax it to or email it to me. Once again, we receive that. We will then send out your certificates. I see there's a question, I'm sure, about pricing. This is the normal price of the system, $4,500. This is the VELscope with the adapter. There's some disposed paper caps that you're going to want to use, brochures, posters, and so forth. The TDA purchase program, sort of a pre-launch, and I can tell you with no equivocation that this is by far the best pricing out there. From that $25.95, which includes what we call our bundle, which is everything you need to get up and running. And literally by the time you either reorder any disposables or brochures or what have you, assuming you're charging for it, it should be paid off, especially at this discounted price. So I'll put up, again, that's my cell phone number. I'll open it up for any questions that we might have. Can anybody hear me? Or are we good?
Evan, I have a question. This is Donovan. If anybody else has questions, feel free to type them in on the right-hand side, and we'll get them to Evan. How long does it typically take somebody who just purchased this program or this product to get up to speed with it?
That's a good question, Donovan. So normally what I say is the learning curve is about 5 to 10 patients. And it's really not what we're looking at. It's just getting comfortable with your distance. Obviously, you have one hand, so if you wear loops, getting comfortable with with the distance. You know, we recommend that you want to be as perpendicular to the tissue. So, you know, we're going to have the patients move their head a little bit more than normal when we're doing our exam. But that's where I find the learning curve is getting to a level of comfort in terms of the examination process itself. In terms of, you know, the reality is, fortunately, hopefully, we're not going to find oral cancer the first day. But that's generally where, so it's fairly quick, and everyone's going to be different. Also, part of it is how comfortable you're doing a white light exam. If you're a little less comfortable, your learning curves are going to be a little bit more, because this is just basically reinforcing what you should be doing when it comes to a white light examination.
Thanks. All right, ladies and gentlemen, if you have any other questions, also feel free to email Evan at the email address he had up, or give him a call. If we don't receive a question here in the next minute or so, we'll go ahead and end the webinar. Again, just a big thank you to Evan and TDA Prick Supplies and VELscope for giving us this opportunity. And it looks like we do have one from Dr. Patel. What is the rate of false positive detections by dentists?
Thanks, Dr. Patel. So, Dr. Patel, you know, false positives are actually subjective, right? Because your definition of a false positive, so let me step back. The true definition of a false positive is normal, healthy tissue that appears abnormal. So we feel pretty confident when something's showing up darker in the VELscope, it's something abnormal. Now, our goal is to assess, is that abnormality something that's trauma or inflammatory versus versus obviously dysplastic or cancerous. And there's still some subjectivity in there, obviously. But I guess utilizing a very limited study, if you will, you're talking about it. Even if you want to use a traumatic lesion as something you're referring as a false positive, which in my opinion is not, you're still looking at less than 10%. If you look at that study that I referenced from Dr. Lalonde, she actually stated that she referred less patients than she was referring before, and the patients she did refer, she had a higher correlation with something that required a diagnosis, and I think that's the more important thing. So I would say in theory, we really should be talking about false positives. We should be talking about confirmation of diagnosis. And if that's our goal, you should be probably referring less patients if you're utilizing this effectively.
And I'm going to unmute Dr. DeWald. Dr. DeWald, did you have a question? I saw you raise your hand. If you do, I have a chat message that I sent over to you.
I don't see anything.
Oh, no, Dr. DeWald, I was.
Oh, sorry.
I sent them. Yeah, no, not a problem. Okay. Oh, she said sorry, or she said sorry, no.
Okay.
All right, are there any other questions, ladies and gentlemen? Anybody else that has a question for Evan while we've still got him on the line? Okay, well, thanks again for your time, everybody, today. This webinar will be put up on the TDA Perks website, tdaperks.com, under the Articles and Resources section next week. You can start finding that, and by next week, I mean the week after next, sorry. And it will be on there for quite a while. If you have any other questions, again, Eben Turner is available for questions afterwards, and big thanks to them and VELscope and TDA Perk Supplies, and we really appreciate your time today. I hope everybody has a wonderful weekend and have a safe day.
Thank you.
Thank you very much, and this will conclude our presentation for this afternoon.